Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Treatment of Children and Adolescents with Hodgkin Lymphoma Without Radiotherapy for Patients in Complete Remission Following Chemotherapy. Final results of the multinational trial GPOH HD 95 by Wolfgang Dörfel and colleagues. My name is Monika Metzger, and I'm an associate member at St. Jude Children's Research Hospital in Memphis, Tennessee. My oncology specialty is hematological malignancies, particularly Hodgkin lymphomas. According to the Surveillance Epidemiology and End Results database, every year more than 1,100 patients under 20 years of age are diagnosed with Hodgkin lymphoma in the U.S. Fortunately, around 90% of these patients can expect to survive this diagnosis with modern multi-agent combined modality therapies. But this rapidly growing population of childhood cancer survivors will suffer lifelong consequences and late effects of therapy. Long after completing treatment for Hodgkin lymphoma and leaving their pediatric cancer centers, aging survivors are at risk of cardiopulmonary dysfunction and second malignancies, the leading causes of death more than 10 years after the original diagnosis. It is therefore not surprising that one of the main goals of pediatric oncology groups has been to tailor therapy to reduce morbidity and mortality while maintaining efficacy. It is undisputed that Hodgkin lymphomas are exquisitely sensitive to radiation therapy. In fact, before the 1960s, this was the only curative modality for lymphomas. But the doses and fields required to achieve disease control in children led to unacceptable musculoskeletal deformities, and aging survivors experienced excess risk of subsequent cancers, especially breast cancer and cardiovascular disease. In the 1960s, the development of MOP, an efficacious multi-agent chemotherapy regimen combining meclorethamine, vincristine, prednisone, and procarbazine, led to improved survival, especially for patients with more advanced disease. Nonetheless, the initial excitement was soon dampened by the discovery of infertility and secondary leukemia associated with the regimen. In the following decade, the development of ABVD, a combination of doxorubicin, bleomycin, vinblastine, and dacarbazine, provided an alternative, efficacious regimen that did not result in gonadal dysfunction or secondary leukemogenesis, and is still considered standard of care for adults in the U.S., more than 35 years later. However, doxorubicin and bleomycin used in this regimen produced a dose-related risk of cardiopulmonary toxicity that has remained a concern for pediatric oncologists. To address this problem, derivatives of these two regimens were developed. As a result, a combined modality approach evolved in which radiation therapy replaced cycles of chemotherapy, and treatment was stratified to limit intensive therapy to patients with advanced disease, sparing those with localized disease. Adult oncologists were quick to eliminate radiotherapy for many early-stage and intermediate-risk patients, instead giving higher cumulative doses of anthracyclines and alkylators. Pediatric oncologists hesitated to make this trade-off. Early North American randomized pediatric trials showed improved event-free survival using a combined modality treatment approach compared to chemotherapy only. Yet, event-free survival may not be an adequate measure of the effectiveness of different treatments, since most patients with Hodgkin lymphoma can still be successfully retrieved after relapse. A 2012 report in the New England Journal of Medicine by Maya and co-workers demonstrated this concept very convincingly. A group of adult Hodgkin lymphoma patients treated with ABVD alone were initially thought to have worse outcome due to inferior progression-free survival at 5 years compared to patients who received radiotherapy, but they had superior overall survival 12 years after diagnosis. One of the most admirable attributes of the pediatric German-Austrian legacy trials is the systematic approach in which each trial builds on what was learned before. These studies started in 1978, after MOB had been found to cause infertility and secondary leukemias. Therefore, the German investigators chose to substitute doxorubicin for meclorethamine in the first 2 cycles and cyclophosphamide for meclorethamine in the following 2 or 4 cycles for intermediate and higher risk Hodgkin lymphoma. Thus, they created the OPA regimen of vincristine, prednisone, procarbazine, and doxorubicin, and the COP regimen of cyclophosphamide, vincristine, prednisone, and procarbazine. They expected drug-related cardiac toxicity to be low, with only 160 milligrams per meter square of cumulative doxorubicin exposure. Since then, the studies have aimed at determining how much chemo and radiotherapy could be safely reduced within the context of a combined modality approach while maintaining excellent results. The first 5 studies focused on reducing the dose and volume of radiotherapy. Extended field radiotherapy to 35 gray was successfully reduced to involved field radiotherapy to 20 to 25 gray. A review of the late effects of the OPA and COP regimen showed only a 0.5% cumulative risk of secondary leukemia for the first 10 years, which was much lower than with MOP, and no cardiomyopathy, which would have been expected with ABVD. Unfortunately, increased follicle-stimulating hormone suggested impaired spermatogenesis in 30 to 60% of male patients, depending on the number of cycles they had received. In an effort to maintain fertility in boys, the HOT 85 trial omitted procarbazine in the first 2 cycles and substituted methotrexate for procarbazine in the following cycles, but outcomes were inferior. In the HOT 90 study, boys received etoposide instead of procarbazine in the first 2 cycles, creating the OIPA regimen, while girls continued to be treated with OPA. This substitution produced outcomes equivalent to OPA for boys with low and intermediate risk disease, but boys with stage 3B disease fared significantly worse. The GPOH HD95 trial is the 6th trial of this series, and the first to try to eliminate radiotherapy for patients in complete remission at the end of all chemotherapy. This large multi-institutional trial followed 925 patients for more than 10 years and found that radiotherapy could be eliminated for low-risk patients who achieved remission after completion of 2 cycles of chemotherapy, 25% of this group, with equivalent outcomes to those treated with chemotherapy and radiotherapy. Disappointingly, patients with intermediate-risk disease who achieved a complete response to chemotherapy had significantly lower progression-free survival without radiotherapy consolidation. Progression-free survival was 68.5% for patients treated with chemotherapy alone, compared to 91.4% for those who received combined modality therapy. Interestingly, the 20% of patients with unfavorable risk disease that did not receive radiotherapy consolidation did not fare significantly worse. Their progression-free survival was 82.6% compared to 88.7% for patients who received combined modality therapy. The authors attributed the lack of significance to the small patient numbers. I, on the other hand, am more inclined to believe that the 2 additional cycles of chemotherapy they received may have attenuated the need for radiotherapy. In adults, it is well established that when very intensive chemotherapy is given, radiotherapy can be reserved for those who have residual disease at the end of chemotherapy. Lessons learned from the GPOH HD95 trial were successfully implemented in the GPOH HD 2002 trial, in which etoposide was given for 1 extra day for a total of 5 days, with a cumulative etoposide dose of 1250 milligrams per meter square. This strategy allowed all boys to be treated without procarbazine in the first 2 cycles, and the investigators also substituted the less gonadotoxic dacarbazine for procarbazine in the following cycles. Radiotherapy was omitted only for low-risk patients in remission after chemotherapy. This trial, reported in JCO in 2010, proved both chemotherapy regimens, OPA-COP for girls and OIPA-COP-DAG for boys to be equivalent. Another concept that emerged from the GPOH HD95 trial was not immediately evident, but proved to be important and was discovered at the same time on the other side of the Atlantic. The Pediatric Oncology Group had just completed a parallel trial alternating MOP with ABVD, which showed inferior results for patients in complete remission at the end of all chemotherapy who did not receive radiotherapy consolidation compared to those that did. Hidden in both trials was a new paradigm. Response after early chemotherapy cycles might identify patients who could safely forgo consolidation with radiotherapy. With this finding, a new era of early response-based therapy began. Globally, all modern pediatric trials are now refining this concept using CT and/or PET imaging criteria to better identify patients with favorable risk features and rapid responses for whom radiotherapy may be avoided without compromising long-term survival. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.